Oh, it does it automatically. Right. Hi, everybody. Lots of people are joining us now, which is great. It's good to see everyone. Thanks for being with us. We're going to give time for people to come from their busy lives to settle into the programme. But thank you for making time to be with us. We're just going to give a few more minutes and allow everybody to come and join the link and be welcomed. So get comfortable. There's lots of time for you to get a drink, have a refreshment, relax. It's nice sometimes, isn't it, to be able to join these from the comfort of wherever you are, or sometimes you have to join them and you're travelling. And it's nice that you can listen in and not miss opportunities to learn together. So it's lovely to see people arriving. See AJ, Kira, Joanna, Nicola, Rashmi, and Samantha. It's nice to see you. Hi, Joanna. Lovely to be with you. So just as we're waiting for people to join us, we can just give you a little bit of an idea of how to use the functionality of Zoom. If Zoom's new to you, you should be able to see that there's a chat function, a little chat bubble. If you're on your phone, you just press your screen and then you'll see some of the icons. If you're on your desktop computer, you'll be able to zoom your mouse around the screen and you'll see some icons pop up at the bottom. So we're going to be using some of those as we work through this taster session. I'm so excited. So I just got a little bit more time to welcome people in. We've had 44 people register for this taster session, so it's hopefully people can arrive and join us. I'll just give it a little bit more time. Sometimes when you're getting ready to join a session like this, you flurry, it's sort of rush, don't you, to find your link and to find the Zoom link to come in. Oh. Hey. Welcome, everybody. So I think we'll make a start and people will continue to arrive, which will be really lovely. So for those of you that have just arrived, just to let you know that you can see a participant list on the icons if you hover over your screen, and you can open the chat and chat to each other and use the chat function throughout the taster session tonight to discuss, ask questions and communicate with us and each other, which is lovely. So welcome. My name's Anna Byram and I'm one of the directors of All for Maternity, a learning, sharing and caring platform for everybody that works with and supports families using maternity and perinatal services. And I'm really delighted tonight to welcome colleagues and friends from the White Ribbon Alliance. So a warm welcome to Leah, Amity, and I think Julie's arriving as well, which is really lovely. I can see that, Julie, you're just arriving, which is great. I'm just going to make you a co-host so that you can show your beautiful face. Thank you so much for being with us and to being together this evening. So we're really delighted to be able to host this taster session and you're going to be introducing more about the programme that you're offering. So over to you, Leah.
Good afternoon, everybody. Again, thank you all for joining us. It's a real pleasure to be here with you this evening. I do apologise. I'm just going to play you a quick introductory clip.
Leah Lewin, perinatal specialist and business development consultant for White Ribbon Alliance UK. I have a keen focus in Black maternal and infant health with a specialist lens and interest on the impact of intergenerational trauma, and it's a pleasure to welcome you to this taster session of our Free From Harm training. My colleague Amity Reid is a qualified midwife and author and has been working to tackle obstetric violence for many, many years. She's also authored our Free From Harm resource, leading to us co-creating our flagship training. White Ribbon Alliance UK is an independent charity working in alliance with other partners across the globe. We focus on using a human rights framework to advance policy, programme and practice in the areas of abortion, maternity, menopause, sex education, LGBTQ+ rights, female genital mutilation, gender equality, gender-based violence, economic justice, period poverty, asylum seekers and refugees. We envision a gender-equal world in which all people realise their right to quality health and well-being. Our mission is to enable a people-led movement that asks, listens and acts to advance sexual and reproductive health rights. Our approach is both simple and effective. We ask, we listen, and we act. You can read more details on the way we work on our website at www.whiteribbonalliance.org.uk or www.freefromharm.co.uk. We are an inclusive organisation, so you may notice that in our language, as it will reflect that. We're very clear on our beliefs and our boundaries.
So background for Amity, my colleague. She is the training and resource lead for White Ribbon Alliance UK, registered midwife, an activist and freelance journalist. If you haven't already, please do check out her book. She is the author of Overdue, which focuses on birth, burnout, and it's a blueprint for a better NHS. And she's been writing for over 15 years now to tackle obstetric violence. So again, on behalf of myself and the team, thank you all for joining us this evening. We're going to start with a poll, just so we can get an idea of what obstetric violence means to you. So I'll give you a few moments just to add your thoughts. You can see them all coming in now. Just a couple more. Okay. Okay, thank you, Anna. So we have 8% anything done without consent, 8% unnecessary interventions, 8% for physical assault, 8% for emotional manipulation, and 100% for all of the above, which is great. I think it looks like the individual ones that were tagged were a collective voice from one person. Okay, thank you very much, Anna. So it's good to see that you have an understanding of obstetric violence. So to give you some more detail, obstetric violence is a form of gender-based violence, and it occurs all over the world in both high and low income countries. The intent, the profession, the sex or gender of the abuser is completely irrelevant. The act of obstetric violence is not about that individual, it's about the person that has experienced it themselves. So disrespectful maternity care is rooted in a patriarchal and white heteronormative power structure that is found within medicine. And it's been documented throughout history to have racist practices. The term obstetric violence originated in Venezuela in 2007, when there was little to no midwifery presence, and it was coined to describe very specific abuses to begin with. And that was things like unnecessary cesareans, unnecessary intervention of any sort, examinations without consent, separation from your baby or your partner, and disrespectful and abusive treatments. In more recent years, it's been expanded to cover various areas and elements of violence against birthing people within the perinatal period. So it's not solely around birth. There is a strong history of paternalism in the medical system, particularly in reproductive health. And there's still a lot of controversy over the term and why we choose to use it. But it's really, really important that we stick to language that is powerful, even if it causes discomfort. And we acknowledge the harm and the trauma that's being inflicted on those people by those actions. We don't say to victims of domestic or sexual abuse that they were participants in the trauma that they experienced, because it minimizes what's happened to them. And it's insinuating that there's some sort of normalcy around that, which is not true. It's not the case. So by addressing how harmful it is and how strong the impact is, it helps to highlight how detrimental obstetric violence can be. Do apologize if you can hear any background noise. It is half term.
Thanks, Leah. So yeah, I'm Amity, everyone. Nice to be here this evening. So just to carry on with that nice introduction from Leah, one of the ways that we talk about obstetric violence in the training course and in the Free from Harm resource is by utilizing this power and control wheel. So just give you a really brief background of it if you're not familiar with it. The power and control wheel is used in domestic abuse education. It's called the Duluth model, and it is used to help educate both perpetrators and victims of domestic abuse in how it manifests. So as we know, with domestic violence, it used to be thought of as solely, a person physically assaulting or beating someone, and we didn't necessarily consider things like emotional abuse, financial abuse, isolation, manipulative behavior to be abusive. But we know that now we are more recognizing that domestic abuse can be any of those things, and that at the center of it is power and control. So again, like we'll talk about in a moment about obstetric violence, it's not necessarily about a person intentionally setting out to harm someone, but because of either an uneven power structure between them or in their relationship, or for a variety of other factors, if there's an element of power and control over another person in that interaction or relationship, it's more likely to be unequal and for there to be an abuse of that power. So we took this wheel as inspiration to help talk about obstetric violence. And again, broadening out from that definition that Leah just talked about, where it was first used to talk about just a few really specific instances, we're now beginning to understand from people's stories and just from more research and education around obstetric violence that just like domestic violence victims, that people who experience obstetric violence also have long-term emotional impacts, that they can have PTSD from it. It's creating a lot of birth trauma. So we wanted to utilize this wheel to help to contextualize how we talk about obstetric violence. So what we did was we had some focus groups with people who've experienced obstetric violence, both in person and online. And we asked people to just talk about their experiences and how they felt like they manifested. And these were the categories that we came up with at the end of those, talking to all these people, was that it's not only the physical elements, like, for example, being forced to birth on your back or to be in a certain position or to withhold food, drink, or medication, or to do any unnecessary interventions, but also emotional. So isolating you from your partner or baby, undermining your autonomy, making you afraid to ask for help, also using an emotional manipulation to try to influence your choices without the information to go behind it to make that informed consent. These are all forms of abuse, and they are, again, centered around power and control. And we know that when there's such a massive system like we have in the UK with the NHS, and as we all know, it's very understaffed, the staff are very overworked at the moment, and I do still firmly believe that nobody means to do anyone harm if they've gone into a caring profession, but the fact is this harm is happening, and we need to understand better how it happens and also how we can recognize it, so that we are recognizing that it's not only the really clear-cut cases of like physical assault or abuse that are harmful, but also all of these other ways that it's harmful, and that also includes institutional harm. And also want to be really clear that when we say obstetric violence, we're not talking about solely obstetricians. It can be anyone, regardless of their sex, gender, profession, or whether they intended to do harm. It can definitely, absolutely be midwives, nurses, maternity support workers, anyone who has contact with or cares for people giving birth. They have the ability to inflict this kind of harm. But again, because of the history of it, it is still called obstetric violence, but it's more about the model of care rather than obstetricians themselves. It's really important that we talk about the personal experiences behind obstetric violence as well. So in the training, we go much more in depth about this. We actually show some video footage that's very emotive. We have many more examples, but this is just to give you a little flavor of some of the experiences that have been shared with us. These are all found in our free resource online. But we do feel it's really important to hear these stories, even though they can be difficult, because this is the reality of the impact on people. And we need to be mindful that just because we as healthcare professionals might not see people in the days, weeks, months, and years and decades after they give birth, we know that those experiences stay with them for a very long time. And we need to know what the long-term impact is, even if we're not seeing it up close and personal. So I just wanted to share a few quotes that were shared with us. These were all submitted by people through a community project to help share people's birth experiences called They Said to Me. I won't read these ones out because they've probably been up long enough for you to have read them, but very upsetting and harrowing quotes. I think we would all agree. And these are just a couple more. The one at the top really struck me as well, because that's not something that we would maybe necessarily consider to be obstetric violence, but not being given information to be able to make an informed decision is also about power and control. So not wanting to, a doctor saying that I'm not interested in evidence, I'm interested in lives. That is very much about saying I have the control and I have the power in this situation. And that is stripping someone of their autonomy, their right to make an informed decision. And it's essentially saying, do what I say, because I know best. I'm the person with the power here. And that is a form of abuse. And then we can see here at this bottom quote as well about someone who had experienced sexual assault and was a survivor and had asked not to have any vaginal examinations, to be repeatedly asked to have one over and over again would itself be traumatizing. And it just shows that we absolutely have to be mindful of not only our language, but of placing protocols and the way things are normally done over individuals. Because if you had taken the time, to speak to someone on an individual basis and understood their reasons for maybe not wanting to do things the way that they're normally done, then we can very easily see how we'd be able to form a better relationship. But by ignoring that individualism, it's very difficult to be able to have that kind of trusting relationship where they would feel able to do that. So it's just really important to be mindful of that. And in the full training, we go into this in a lot more depth. We also talked to midwives. So we wanted to also speak to midwives and say, what's going on with you? Having worked in the system myself and still being a midwife, I know what it's like to be in that system, to be really overworked, to be under-resourced, exhausted, burnt out, trying your best and still feeling like it's not good enough. And it is really demoralizing. So we wanted to get midwives' input as well. And these are just some of the quotes that were given to us. So saying like, I used to be confident and stand up for what I believe in, but the system has worn me down. I think that's a quite common sentiment. And this one in the middle particularly hit me as well, saying, here I am in debt, physically exhausted, emotionally drained, unable to sleep without medication. That says it all really, doesn't it? Because if you're feeling that way, how good a care are you able to give, and how empowered will you feel to be able to give that individualized care that people so desperately need? And I will hand back over to Leah.
Thank you, Amity. So one thing you will hear me and Amity talk about repeatedly, both here and also in the full training, is the importance of language and how our language can impact others. Ooh. So I want to talk a bit about the impact versus intent, and we're going to look at this through an intersectional lens. So understanding the difference between the impact and the intent is really, really crucial. And especially when you're considering LGBTQ+, neurodivergent, disabled, and cultural minorities. Obstetric violence, as we said, is defined as the mistreatment of women during childbirth and pregnancy. And as with most things, like we're becoming aware, it disproportionately affects and impacts marginalized groups, particularly those from minoritized ethnic backgrounds. And this disparity is rooted in a complex interplay of systemic bias, socioeconomic factors, historical inequalities, and the main disparities experienced by these groups in the context of obstetric violence, sorry, excuse me, are listed on the screen. So to give you an idea, there are higher rates of mortality, maternal mortality and morbidity. Again, that's something where there is lots of conversations being had now, and it's becoming more commonly highlighted, but we're yet to see any notable improvement or equity here. Inadequate pain management, socioeconomic factors, I always get tongue-tied with that one. Limited access to informed consent, especially if you consider non-native speakers. They may face challenges in understanding medical information, which can lead to the miscommunication and inadequate care. Cultural insensitivity. Healthcare providers may lack awareness and or sensitivity towards cultural practices, beliefs, and behaviors of minoritized women and birthing people, which leads to a mismatch in the care that's being provided and the patient's needs and expectations. Women from minoritized groups often report a lack of respect during childbirth. The specific needs and experiences of disabled and LGBTQ+ individuals, particularly those who are pregnant or seeking reproductive care, are often not well understood or acknowledged in the healthcare setting. And this lack of understanding can lead to actions or policies that, despite having good intentions, may have really negative impacts on those individuals. And healthcare providers may also make assumptions about a person's gender identity, their sexual orientation, or family structure. So, for instance, assuming that all pregnant individuals are heterosexual women can lead to inappropriate or disrespectful care. And while these assumptions may not intend to cause harm, we all know it can create a hostile and very unwelcoming environment for people, which leads to psychological distress and a lack of trust in healthcare providers and the system. So to highlight the key elements that, a few of the key elements that we discussed throughout the full training are the limited understanding and recognition, the clinical biases, assumptions and stereotypes, which is a huge one, addressing biases, invisibility and erasure, and barriers to accessing care. And one which I think needs a lot more focus is the lack of tailored healthcare policies and training. In healthcare, particularly in obstetrics and gynecology, there is often a heteronormative and cisnormative approach to care that can lead to the erasure of people's identities and experiences, making people feel invisible and further marginalizing them within healthcare. The disparities in the impact versus intent on an individual with disabilities, especially at this intersection, arises from systemic issues in healthcare, including a lack of understanding, biases, inadequate policies, and training. Training is a key element that would need to be addressed. These factors contribute to a healthcare environment, again, with actions and intentions of providers that may not align with the specific needs and experiences of patients with disabilities, for example, leading to impacts on their mental health and their own well-being. Hand over to Amity.
Sorry, just went back a bit too far. Back. There we go. All right, so one of the best things about the Free from Harm training, and we've got some fantastic feedback on this when we ran the pilot sessions, is the fact that we don't only talk about obstetric violence and about, you know, all of the problems in maternity care. We actually equip you with some tools so that you can effectively challenge it and address it, not only within yourself, but in others. So if you see poor practice, then you'll feel more confident by the end of the training that you could address it. So we do this mainly by teaching a graded assertiveness tool, and then by going through practice scenarios with that tool. So the graded assertiveness tool just, again, helps you learn how to challenge poor practice and harmful behaviors, and then having the opportunity to then immediately put that tool into practice is really helpful. And we got really good feedback on that was one of the most helpful things about the training, was leaving it feeling like you had practice at actually doing it. And I'm a firm believer that just like we practice emergencies and skills and drills, this is something we should be practicing. And I would encourage anyone, whether you do the training with us or not, to come up with your own scenarios that you've seen yourself, or that you can you know, come up with reasonably, and just practice what you would say in that situation. So we're going to really quickly do a practice scenario. I know we don't have a huge amount of time, but we'll just go through it quickly, and hopefully I'll have time to take just a couple of quick comments on it. So I'll just read it out. You're a newly qualified midwife caring for a woman having her first baby. Michelle has a history of anxiety and is accompanied by her partner, Sean. After 2 hours of pushing, the new obstetric registrar, Jane, recommends a forceps delivery due to fetal position. A consultant anesthetist, who is known for being grumpy, shouts at Michelle for shaking while he's sighting the spinal. Afterward, Michelle tries to ask Jane a question, but the anesthetist, who is visibly annoyed, interrupts and says, "Stop talking, close your mouth, and push when we tell you to. That's all you need to do." Jane looks down at the floor, clearly uncomfortable, but doesn't say anything. A more senior midwife in the room with you also looks disgusted, but remains silent. So I think we can all hopefully recognize why this is problematic. But what we want to think about is not only why it's wrong and why what was said was clearly disrespectful and even abusive, and it is a matter of power and control, but also to think about what all of the different people in the scenario might have been thinking and why they didn't feel able to speak up. So we have not only Michelle, but we've got her partner Sean there. We've got you as the midwife who's been caring for them. There's then another more senior midwife in the room with you, and an obstetric registrar. So I'd love if anybody wants to venture a thought, a comment, or a question about this, or to think, you know, any thoughts you have about what you might do or say initially in that moment, or even afterwards, to address that behavior.
If you want to put your hand up, I can unmute you, and you can ask it, or you can type it into the chat box. People have got a comment. So feel free to pop your hand up if you'd like to make any comments. Okay, I can see your hand's gone up. Thanks, Joanna. Do you want to just unmute yourself if you can? There you go. Hi.
I think it's difficult. I think it depends on where you are in your career. I know that as a newly qualified or early career midwife, I probably wouldn't have known how to deal with that situation, but 10 years in, I think I would have felt more comfortable to say to the anaesthetist, actually, can we talk outside and speak to them about how they're coming across, and be more apologetic to the other people in the room. But I think it can be quite hard to do that, to speak up.
Yeah, absolutely. It is tricky to speak up, but again, that's why we just have to practice it, because there are ways you can do it that are still, and I think the main thing that most people worry about is about still remaining professional, or not wanting to upset or scare the woman as well by having, this disagreement in front of them, and that's very valid. But it's, again, and it is a tricky situation, and there's lots of different angles, but in the full training, this is the kind of scenario that we go through in a lot of detail by doing a lot of group work and reflection, and you get an opportunity to actually think about what you would say and how you would say it. So yeah, those just give you a little flavor of it. But yeah, that's the type of scenario that we do in the training.
Thanks, Joanna.
And I'll hand back over to Leah for the last bit.
Thank you, Amity. Okay, so we hear a lot about self-care. It's become a bit of a buzzword. It's not a bubble bath and a smoothie. They can support your personal self-care toolkit, but we have to take self-care seriously, especially when we're addressing obstetric violence, because the quickest route to burnout as a professional that has the potential to suffer from vicarious trauma, which will impact the care and treatment that you provide, is through a lack of self-care and burnout. Being overworked, being underpaid, having a lack of respect for your personal life and your own personal boundaries. And that goes both ways for both you as an individual and for the organization. Not feeling part of a team or feeling heard or valued, feeling unsupported after traumatic or difficult events, a lack of compassion from leadership. All of these things can lead very quickly to burnout. So to minimize these feelings of difficulty, make your mental wellness a priority. Set healthy boundaries, again, both at work and at home. Maintain a strong support system. Avoid internalizing things that you have no control over. And that one is so much easier said than done. I'm sure we've all done it, maybe more than once or twice, but really learning to avoid holding on to the pain of things that we have no control over. And act to address things that you can influence. Again, this is something that we do cover in a lot more depth during the course, but we use a conceptual framework called the sphere of control, and it's used to categorize elements of your personal and professional life in 3 very distinct areas based on the degree of control that you have over them. So the first one is the things that you can control. That's the first sphere. And these are the elements that are directly within your power to change or influence. The second is things you can influence. So this sphere encompasses elements that you can't directly control, but maybe you can potentially influence through your actions, your words, your behaviors, or by other means. And lastly, the things that you can't control. So my voice has decided now's a good time to go. This sphere includes factors that are beyond your control. These often involve larger systemic issues, the actions or emotions of others, and certain outcomes. They are beyond our control. So learning first to identify and separate those can massively impact how you compartmentalize how you deal with your own self-care and well-being. So we utilize that concept to help gain control and minimize negative impacts as much as we can. So before we go and before my voice disappears, I'd like you to just practice this quick visualization exercise with me. So if you could relax your jaw, relax your shoulders, take some deep breaths, and get comfortable where you are.
Self-care is vital in addressing obstetric violence.
I'm going to skip that part, sorry. Okay, so take a deep breath in and close your eyes. I'd like you to picture a place where every birthing person feels safe, respected, and empowered during their childbirth journey. With you at the forefront of this transformation, having engaged with us on our fully accredited training program, and you've become a catalyst for change. I want you to see pregnant individuals confidently making informed choices about their birth experiences. They are supported and guided by healthcare professionals who actively engage in partnership, advocacy, compassion, and empowerment. Their voices are valued and their autonomy is upheld. I want you to feel a sense of unity and collaboration among healthcare professionals, organizations, and communities. Because together we are all breaking down the barriers that perpetuate obstetric violence. And you're part of a culture of care that is extending beyond the birthing room, that's promoting well-being of families, of healthcare professionals, and of our extended communities. I'd like you to take a moment to acknowledge the profound impact that you can have on the lives of countless individuals and feel a deep sense of fulfillment and gratitude for your role as a change maker in eliminating obstetric violence. Now, as you slowly bring your awareness back to the present moment, know that this vision is not just a dream. It's something that's a reality in the making. It's why we're here. And you are a catalyst for change. And your actions will continue to shape a world where every birthing person experiences childbirth with dignity, respect, and empowerment. Please take another deep breath in and exhale slowly. And gently open your eyes. And I want you all to carry this vision into a world that is free from obstetric violence. I want you to carry it with you so you see a world that is free from harm as you move forward, knowing that you're making a difference. Thank you for having us.
Thank you so much, Leah and Amity, and thank you so much to all of the attendees who were able to make space in their lives to attend tonight's taster session. I wonder if you could share how people could access, how to gain access to the full programme and the course details, if that was something that you could share for people.
Sure. To learn more and equip yourself with all of the comprehensive strategies that we've kind of talked very briefly over this evening surrounding obstetric violence, please visit our website, which is www.freefromharm.co.uk, and you're able to book onto our training from there as well. You can follow us on Instagram. We do put out a lot of information now on what we're doing, and you can also reach out via email, training@whiteribbonalliance.org.uk.
I'll pop the link into the chat so people can link directly now through to that.
Thank you.
So thank you to everybody that's taken time to be with us. Thank you, Amity and Leah.
And just to say to everyone, we're going to be doing a live Q&A right now on our Instagram page. So if you do have any questions that you didn't get a chance to ask, then please do come over to the WRA UK channel on Instagram right now, and we'll do a Q&A for you.
Thank you, everybody, and be well. I put some extra resources of support if you feel that the issues raised tonight have impacted on you in any way. There are resources and support mechanisms in addition to this course for meaningful support for you, because we recognise we are also the people that use our services and know people that use services that we are wanting to obviously strengthen through this work. So thank you to everybody. I hope you enjoyed the session.
Thank you.
Take care, everybody.